All right. With that, let's plan to go ahead and get started. I am going to introduce our speakers. We have three today. First up, Dr. Dylan Baker is an assistant professor in the Division of General Internal Medicine here at Emory and practices at Grady. He received his medical degree from St. George's University of London, followed by residency training and a chief residency in ambulatory medicine here at Emory. He currently serves as the medical director of the Emory at Grady Primary Care Center and as associate medical director of the Grady HIV Prevention Program. His research centers on the implementation of long-acting injectable HIV prevention in safety net health systems. Dr. Meredith Lora is an associate professor of medicine here at Emory and medical director of the Grady HIV Prevention Program in Atlanta. Her research focuses on person-centered, digitally integrated innovation to improve access to HIV prevention and care. As a physician builder and an informaticist for the Ponce Center, she develops EHR integrated prediction models, registries, dashboards, and care coordination tools across the HIV care continuum to advance equitable engagement in prevention and treatment for populations disproportionately affected by HIV. And our final speaker is Dr. Jonathan Colasanti, who received his medical degree and completed an internal medicine slash social medicine and global health equity residency and public health degree at the University of Miami before completing his infectious disease fellowship here at Emory. In 2015, he joined the faculty with a dual appointment in the School of Medicine as well as the School of Public Health. He also serves as the Associate Medical Director of the Ponce de Leon Center Infectious Disease Program of the Grady Health System. His clinical and research interests focus on the delivery of HIV care to vulnerable populations across the spectrum of HIV care continuum. In his research, he seeks to bridge the implementation gap in order to improve the delivery of HIV care by addressing sociobehavioral, biomedical, and system-level barriers. In addition to his Atlanta-based work, he works with a Nicaraguan NGO that strives to improve the delivery of primary health care in Nicaragua through a community health worker model. So with that, please take it away, y'all. Dr. Lora, you are muted.
Thank you. I'm trying to share the right screen and share, and then I will press play on my PowerPoint. Can you see my PowerPoint slides in presenter mode? Okay, great. Thank you so much. We are thrilled to be here talking about the new era of HIV prevention, which has dramatically changed since the beginning of the epidemic and even in recent years, and really spans the continuum from test to prevention to suppression. So let's get into it. Here are disclosures. Broadly, learning objectives, I think you can expect from each of us describing the evolution of these HIV prevention strategies from the beginning of the epidemic until now. There are dramatic innovations that have occurred, and so we'll summarize these advances, but we will also really speak to the dramatic gaps that exist in enhancing the impact of these innovations and advances to actually reduce new HIV infections. We'll talk about how future directions can really bridge these gaps and integrate innovations with population health strategies. So first of all, who are we and where are we, right? So as an academic health center in the South, we live in the location of the United States that is home to more than half of new HIV infections. HIV infections overall have modestly been reduced from early around 2009 until now, not accounting for the dip that resulted from the COVID-19 pandemic that resulted in lower testing rates and falsely lowered our new infection rates for those years. Within Georgia, our state is the top state with the highest rate of new HIV infections among the entire country, second to District of Columbia, which also has a very high rate. If you look at it a little bit more globally, Georgia, our rate for new diagnoses is 26 out of 100,000. You can see it here compared to the South, which leads in terms of the region, and the United States. Zooming in further, where we serve our communities, our rates of HIV in Fulton, DeKalb, and Clayton are nearly 4 times that of the national average. But these HIV infections do not occur uniformly across racial and ethnic groups. Black individuals make up nearly half of new infections and have an HIV diagnosis rate that's 7 times higher than white individuals, and Hispanic Latino individuals, despite making up a minority of the population, account for a larger proportion of new diagnoses. On the individual level, the view is quite challenging to really comprehend. Black trans women have a 62% chance of living with HIV. Sexual minority men have a 50% chance of contracting HIV in their lifetime. If they live in Atlanta, this can be 60% by the age of 30, with an 11% chance per year. 60% of women who are newly diagnosed with HIV are Black, yet account for only 15% of the population. These disparities do not arise from differences in behavioral factors, and rather are the downstream impact of structural racism, social determinants of health, that lead to very high prevalence in smaller sexual networks where even limited encounters with even monogamous relationships can increase your per act risk of getting HIV. And so with that in mind, I want to share really why we are here today. While we will be sharing national guidelines in the era of prevention over time, as we live in the #1 state and the #2 city in the country for new diagnoses, where social vulnerability and in a high incidence area is the primary driver of new HIV infections, we really need to go about prevention in a different way than the rest of the country. And we want to share this new era of HIV prevention. We're in an incredibly exciting time for innovations, but we must innovate in a way that bridges the gap between biomedical and digital innovation to the community. And we are strategically and uniquely positioned to make changes that can impact the entire country. No pressure. So we'll start with a case, a 39-year-old woman who was recently hospitalized at Grady with pneumonia. She was diagnosed with HIV during that hospitalization. She had 8 T cells at the time. In our visit, she shared with me that she had had 3 lifetime partners and didn't understand why she could have gotten HIV. In fact, her current partner from whom she acquired HIV, she had had for the last 8 years. She asked why this wasn't picked up on her recent tests. And when I asked her, you haven't had a recent test, she told me, yes, I have. I've been to so many hospitals. They drew my blood. I assumed I was getting an HIV test. And so if you walk away with nothing else from this talk, please walk away with this. Prevention starts with a test. And if we do not test, we cannot suppress, we cannot prevent, and we cannot get close to ending the epidemic. So let me tell you about our current era of HIV prevention, which builds on this, what's called a serostatus neutral HIV prevention approach. The HIV test is the foundation of this approach, where a test to ideally expanded to all individuals, if negative, results in awareness of one's risk or chance of getting HIV, and then engagement in a prevention pathway where biomedical options are possible and recommended if one's risk is, elevated, which can be challenging, and we'll get into that. If that HIV test is positive, this results in rapid, no questions asked, ideally same day, but within 72 hours is the goal, highly effective treatment where viral suppression will eliminate the chance that that person who is diagnosed with HIV can transmit HIV. Broadly, I want to take you through the HIV prevention advances and how we got to this status neutral prevention approach, and just contrast how different it used to be. In the 1980s to 1990s, behavioral risk reduction at those at the highest risk, like using a condom or not sharing needles, was the primary approach. And HIV testing was only recommended in 1987 for persons at highest risk. Over time, population health strategies and policy have recognized, as we've seen, that suppression of HIV leads to inability to transmit HIV and the ability to enact prevention approaches. The expansion of HIV testing has been dramatic, and I will go into this more in depth in just a moment. In addition, advances in HIV testing options have significantly enhanced our ability to prevent HIV through these mechanisms. And we've moved into a biomedical prevention era and a digital technology era that is significantly enhancing our approach. So all of this has led us to this conclusion that everyone must be tested. And with that test, an awareness of what is needed with rapid linkage to those pathways is what we call that serostatus neutral prevention approach. So why is it so important to diagnose individuals who are living with HIV who are unaware? That test, which is the gateway to both pathways, is critical because people who are unaware of their HIV infection, right now that stands at around 13 to 14% in the US, or actually account for almost 40% of new HIV transmissions. Much of the rest of the transmissions are people who are infected and aware, but not in care. And that piece we'll really talk about with Jonathan. But a lot of times a test can also bring awareness that a person is not in care, and so can be used for that purpose as well. Let's go through this expansion of HIV testing very briefly, just to say that this movement from testing everyone who is just at highest risk moved to, in 1993, the CD recommending HIV testing in hospitals, urgent care, and emergency rooms as part of more routine care, and then recommended routine HIV testing broadly as part of all care. And then we moved to a space where we are testing everyone at least once within an age group. But importantly, that's not highlighted here, we must repeat testing at least annually for people with ongoing possible exposure to HIV. Despite this expansion, we have made some progress, but not enough. Only 30% of people in our youngest age group who are among the highest age group with new HIV diagnoses have ever been tested for HIV. And only 40% of people across the US have ever been tested for HIV. Zooming in on people who are at highest risk, you can see this curve here showing the people who reported an HIV risk factor in the last year, and the number of days since their last HIV test still stood above 365. We really need to get this below 365 more broadly in order to enact that serostatus continuum more frequently at every stage of a test. And so let's talk a little bit about emergency-based opt-out HIV testing and the impact of that, as well as the gaps and where we need to go. So why is testing in emergency rooms so critical? 1/3 of newly diagnosed people with HIV had, let me rephrase that. Only 1/3 of newly diagnosed people living with HIV had even a healthcare visit in the 3 years before diagnosis. Most of those healthcare visits occurred in the emergency setting, making emergency settings a critical location for earlier diagnosis and linkage. So as we discussed, emergency settings are expanding opt-out testing, but we still have a number of emergency settings in Atlanta that are not yet doing opt-out testing. And so this leaves a significant gap in testing opportunities for our community. Let's dive into a case study, testing at Grady, where Grady implemented opt-out HIV testing back in 2013, 2012 to 2015. And I want to, with caution, help you understand that opt-out testing in Georgia is not true opt-out testing because we still require verbal consent. And it is a significant limitation for us to truly expand HIV testing to all, as you hopefully saw in the case study of the young woman recently diagnosed with HIV. We need to truly be testing as part of routine care, and by announcing it and ensuring that we have verbal consent, this may be worsening stigma around HIV and testing and status. But Grady implemented opt-out testing back in 2012 to 2015. As you can see, testing significantly increased over that time period with a small dip from COVID, and we have fully rebounded. Our test positivity rate is higher than the state average at 1.3%, and Grady leads the state for the healthcare system with the top number of new diagnoses. However, it's important to look more deeply at who this intervention succeeded in reaching and who were missed and what was the impact. We found that among 530,000 of people who were eligible, only 37% of eligible individuals received screening over that 10-year period. The impact of this is that 70% of people who were diagnosed anywhere in Georgia with HIV could have had an earlier diagnosis. This misdiagnosis led to a higher odds of advanced HIV at the time of diagnosis with a CD4 less than 350, and people who had missed opportunities for testing went 3 times longer between the last negative HIV screening and their diagnosis, leading to a longer period of undiagnosed HIV infection and a period of acute infection, both with high transmissibility. When looking at the reasons why these occurred, we found that coming in with sexual health related complaints led to testing and reduced the chance that testing would be missed. This is indicating that while opt-out testing has been in place, risk-based testing is still occurring and accounting for at least some of these missed testing opportunities. Although we haven't been able to dig into stigma-related declining of testing in individuals who are offered. Let's move on to advances in HIV testing, and I will just breeze over this slide to tell you that HIV testing has had significant advances since earlier in the epidemic. Advances occur in the lab and in healthcare systems, but also importantly at the community and the point of care level to really enhance access to this vital testing opportunity for everyone, regardless of if they're in care. Earlier tests had longer window periods and were antibody only. Later testing focused on, obviously developing our molecular assays, in developing rapid assays, and even recently, an assay that can reflex to both an antibody confirmation and a qualitative RNA to rapidly confirm both acute and chronic infection in all positive screens. What's the impact of this advancement in our ability to reduce new infections? We studied missed and delayed diagnoses of acute HIV at Grady over that 10-year period. Essentially what we found that with an antigen antibody test that reflexed only to an antibody without reflex RNA testing, even with full-time navigator support, we had people with acute HIV, 43% of people with acute HIV had confirmation delays exceeding 30 days or were never confirmed. Keeping in mind that people with acute HIV are 26 times more likely to transmit HIV, representing a vital missed opportunity that can be addressed if dual RNA reflex along with an antibody test is included in your opt-out screening measures. Further advances in HIV tests more recently include multiplex tests, multiplex point of care to test comorbid STIs and other infections like Hep C and Hep B. And now in this digital age and AI and machine learning solutions, there are now solutions being explored mostly in non-US locations that can track results, basically use AI and enhanced digital methods to respond with linkage opportunities, and even help interpret and contextualize results for people. But the question is, how can we use these at the point of care in our community to actually enhance the number of people who are tested, linked, and on prevention? And so testing innovations and accessibility are coming along. We really need to see more non-medical site expansion. We really need to see more self-testing, and the CDC is actually enhancing this with a Take Me Home program of self-tests. And we really need to capitalize on our AI and machine learning to include automated results interpretation and automated linkage options. In order to move from tests to biomedical prevention or treatment, biomedical prevention, we have to know who would benefit from enhanced or biomedical prevention versus who should keep going with their daily normal lives. And so this is a really, really hard question, because as we talked about, routine sexual behavior in Atlanta or in a high incidence area where the prevalence of people living with HIV is very high, risk can be very challenging. The USPSTF gives a grade A recommendation to prescribe PrEP for people at risk for HIV. And just summarizing this very briefly, CDC guidelines really focus on behavioral risk factors for HIV, but do expand and consider this inconsistent condom use or unknown partner status. They do mention to account for epidemiologic and partner factors, but I think in a place where the prevalence is so high, this is really front and center because partner status is a big question mark for many people. And so challenges in risk assessment really limit our ability to bridge from test to prevention or treatment. Risk is truly a complex interplay of social, structural, network, and behavioral factors that are very hard to identify at the point of care. In addition to the network factors that I've already mentioned, we can see clearly that stigma is really worsening, or it's precluding people from being able to share their true sexual orientation or their true risk behaviors that then leads to non-disclosure of these behaviors to partner clinician. Indeed, like risk scores that use behavioral factors looking at how to prevent HIV in Atlanta it really did not work. This is an area under the receiving operating curve that shows a prediction model using behavioral criteria, 3 different ones, and found that their prediction was similar to a random guess. For women, this is particularly challenging because many women, because of the stigma precluding the disclosure of same-sex behavior, many women may have no idea that they are at risk for HIV in a monogamous relationship. A survey, Zandretta Timms Cook did a study evaluating women diagnosed with HIV in Atlanta and found that the majority of people had one partner or longitudinal relationship with the acquisition partner, were unaware of partner's HIV status or bisexual status. And I'm going to skip this slide, but just to say that the result of this was many women living with HIV got together and said, what do we want? What do we wish for to prevent HIV? And this was the foundational piece. Recognizing risk, partner characteristics may increase your risk, and anyone can acquire HIV, not just individuals with specific behaviors. Indeed, at Grady, we did a retrospective analysis of women diagnosed with HIV and found that sociostructural factors were similarly significant at the individual level for predicting HIV, like living in a high incidence zip code or changing of addresses over time or high social vulnerability index. While similar at the individual level, they are significantly more prevalent in the group diagnosed with HIV. When you combine these 2 factors, you get a population attributable fraction. And what we found is that the population attributable fraction, meaning that if you got rid of this risk factor, how many cases could it avert? We found that behavioral factors had minimal population impact, and social, structural, and healthcare engagement and mental health factors had much greater population impact. So it brings us back to who should be on PrEP. Everyone should be offered PrEP, right? PrEP is not just for certain people. We have to stop repeating that over and over again, using words like PrEP candidate, PrEP eligible. Everyone is PrEP eligible if they're not living with HIV. And a decision to start PrEP must be a choice that is offered to everyone. But digital innovation can improve our ability to identify risk in individuals. Machine learning models can take broader risk factors, including sociostructural, behavioral risk factors, and network factors to predict HIV more accurately. We did this at Grady. We developed a machine learning model.
I can suppress this thing that.
And we really emphasized sorry, I just want to make sure we're not about to get another interruption.
You're good.
Okay, we really emphasize the social features within these models to enhance the social vulnerability to predict HIV. And we found in the first model to predict HIV in Atlanta that it was highly accurate.
Fresh. No. You don't hear anything now, do you?
No.
The model characteristics found that social and structural determinants of health were highly impactful and that behavioral features were not impactful or
That's
were
what I
much
keep
less
doing.
impactful. I'm
And I
sorry.
keep,
So, in summary, we really have moved from a place where we must test everyone, regardless of our perceived risk for HIV or their perceived risk for HIV, and offer everyone the opportunity for prevention and treatment as soon as that need is identified through a test. Handing off to Dylan Baker for the state of HIV pre-exposure prophylaxis.
Thank you, Meredith. My name is Dylan, and I'm going to run through the state of HIV pre-exposure prophylaxis, or PrEP, with a focus in the United States. Next slide, thank you. So running through our menu of options, we have TDF-FTC or Truvada and TAF-FTC or Descovy, both of which are daily oral dosing. More recently, we have some injectable options that have become available with cabotegravir or CAB, which is an injection intramuscularly every 2 months. And we're very excited about lenacapavir release this year, which is a Q6-month subcutaneous injection. Next slide. So running through some of the data behind these modalities, meta-analysis of Truvada versus placebo showed a 56% relative risk reduction for HIV acquisition. However, that really doesn't tell the full story here. Next slide. When you look at a subgroup analysis of these studies, those who have higher adherence with Truvada as measured by blood levels of tenofovir actually had approaching 100% prevention of HIV acquisition. Next slide. And so looking at all of these different subgroup analyses from these initial studies, we come to the conclusion that oral PrEP is fantastic as an option for HIV prevention. However, it really only works in those patients that have higher adherence to taking an oral daily pill, something that's hard for many of our patients to do. And so the Discover study, which studied TAF-FTC or Descovy, showed that Descovy was non-inferior to Truvada. There was a trend towards less infections in the Descovy arm. And unfortunately, this trial was only conducted in men who have sex in men and transgender women populations and excluded cisgender women. Next slide. Along with the evidence of Truvada being mostly effective in patients with higher adherence, all infections in the Descovy arm in the Discover trial occurred in patients with poor adherence. And so just like Truvada, Descovy is really effective. Its effectiveness is dependent on its adherence. Next slide. And if you can advance here as well, I'm going to do an abbreviated version to stay in time. So these are both excellent options. They're both really effective, and they're actually both really safe for patients as well. Truvada is associated with a slight increase in proteinuria, and so we reserve it for those with a creatinine clearance over 60. It also has been shown to have a very small decrease in bone mineral density, although importantly, this was never associated with an increased risk of fractures, whereas Descovy doesn't have the renal and bone effects, but has a minimal increase in LDL and triglycerides and a small increase in body weight. Notably, Truvada is now generic, whereas Descovy is still brand and costs almost $2,000 a month. When we talk about cost with these PrEP options, though, I want to emphasize that none of our patients pay any money out of pocket for these, as we're able to get them for free with patient assistance, copay programs, and other medication access programs. Next slide. So we have two amazing oral PrEP options, and we were expecting to see a huge decline in HIV incidence across the country. But as Meredith outlined, we haven't seen the progress that we were looking for. So whereas PrEP coverage increased from 0 to 26%, our incidence rate didn't decrease by 26%. However, when you look at individual states and you group them by high PrEP uptake versus lower PrEP uptake, with low PrEP uptake being on the left and higher on the right, those states with higher PrEP uptake had a a larger decrease in their HIV diagnosis rate of 40% in the past decade versus those in the lowest quintile with an increase of 26%. And importantly, like Meredith outlined, um, different population groups are impacted by HIV incidence disproportionately. And unfortunately, oral PrEP did not reach those patients that are most impacted by HIV. African American, lower socioeconomic status, and public health insurance individuals were less likely to get a prescription, less likely to initiate, and more likely to discontinue. Advance. This led to increasing PrEP inequality over time. I was going to explain PrEP to need ratio, but basically here our white populations had greater access to PrEP, whereas Black and Hispanic populations had a stagnant access to PrEP relative to the incidence in those demographic groups. Next slide. That brings us to our long-acting injectable options. HPTN 083 and 084 showed a 70 to 90% reduction in HIV infections in those on cabotegravir versus those taking Truvada. But again, I stress the adherence piece here because most of that decreased HIV infections was due to poor adherence in the TDF-FTC group, with 98% of infections in that group occurring in patients taking less than 2 doses per week. And that's really because there was a 90 to 93% adherence to the injection schedule for those on the intramuscular option. And so long-acting injectable PrEP is really exciting because we're able to have structured adherence protocols to help our patients stay on the medication and be retained in care and protected from HIV. Next slide. That brings us to this year blockbuster trial, Purpose 1, which showed that lenacapavir reduced HIV infections by 100% versus background incidence. I still remember my heart fluttering when I saw this result, followed by Purpose 2, which similarly showed a 96% reduction in men and gender diverse persons on lenacapavir. Next slide. So what's next? Q4-month ultra-long-acting CAB is being studied, prolonging that interval from 2 to 4 months. 365-day coverage with intramuscular lenacapavir is also being studied. And so the biomedical options available for our patients are expanding at a rapid pace with truly phenomenal options that really can help us put a dent in the HIV epidemic. Next slide. And the promise doesn't stop there. There's increased choice in PrEP modalities with a PrEP menu for our patients, lets them choose what will actually work for them, which leads to increased coverage time during times of increased risk exposure of 40%. Additionally, groups that we want to make sure have access to all the options that they would feel comfortable with had high acceptability. For example, here at Emory, we were a site for the Ebony study, which was phase 4 for cabotegravir, showed that 96% of Black women felt either very or somewhat positive about being on CAB-LA. We've also seen high retention in safety net settings, surpassing that seen for oral PrEP, with 80% retention at Grady, replicated at Ward 86 with 85% there. And multiple nationwide implementation studies have shown minimal to no seroconversions for those patients on intramuscular cabotegravir. Next slide. However, uptake of intramuscular cabotegravir has been extremely slow. Only 2.5% of PrEP prescriptions in 2024 were long-acting injectable therapy. And so when we see lenacapavir come and other options right on our doorstep, we cannot have this kind of low uptake for these really powerful options for our patients to keep them protected from HIV. And so why is this happening? Providing long-acting injectable PrEP is different from doing telehealth and mailing out an oral PrEP prescription. We need clinic space. We need staff to deliver the injections. We need navigators to schedule the injections, to reschedule the injections. We need a medication access coordinator to ensure that the medication is on site, paid for, and ready to go for the patient. I do want to emphasize here that while this is a large upfront investment from health systems in order to get these programs off the ground, we have found that these programs can be self-sustaining with revenue from these programs. And so it does take an initial investment, but it can be self-sustaining. Next. On top of the staffing needs, there's a very complex insurance coverage system. I definitely won't go into medical versus pharmacy billing, but I've spent way too much of the past 3 years trying to figure that out. These complex insurance coverage systems have led to delays in care, with our own program having a 55 delay from referral to first injection, largely due to insurance issues. And that also was seen at Howard Brown. And also, despite Affordable Care Act coverage for these drugs making them free for patients, some patients are still getting bills from some centers for out-of-pocket costs and lab visits, which makes cost still a barrier to access. Next slide. When surveyed across the country, clinics stated that prior authorizations and appeals processes, the medical versus pharmacy benefit issue, need for administrative support were the top reasons for not being able to expand their long-acting injectable programs, leading to this statement authored by many of my colleagues here that we need to cover these under either of these benefits to facilitate access and streamline insurance access for patients. Next slide. So despite those challenges, I do want to emphasize that implementation does get easier after you get started. When surveyed across the country in the Ebony study, healthcare staff concerns regarding cabotegravir decreased after implementation, from cost to concerns about travel to ability to keep injection appointments to keeping patients motivated, all decreased across the board. Next slide. Here at Grady, what we're studying is incorporating point-of-care HIV testing to facilitate same-day starts, reducing that time from referral to first injection. And we're also happy to see that the International AIDS Society removed the requirement for viral load testing at every maintenance injection for on-time injections, which reduces the cost of delivering this therapy and also makes it more accessible for patients. Next slide. Other programs across the country are implementing mobile buses to deliver PrEP to those communities right where they live, right where they need it the most, including Miami and Yale. And to the right, Miami showed that by delivering care in communities, they were able to have higher retention of their patients compared to their fixed clinic, something that we're exploring and hoping to implement at Grady next year. Next slide. So to wrap up, want to highlight our outcomes here at Grady. We've delivered almost 3,000 injections, which represents 450 person years of protection from HIV infection to almost 360 individuals. We've had 0 seroconversions for patients with on-time injections. And I want to highlight that this is something that is being done at Emory Midtown as well, and at the VA, where they also have hundreds of patients across the Emory system, leading the way across the nation to increase access to these critical therapies. I'm going to hand it off to Dr. Colasanti to wrap us up. Thank you.
Perfect. Thanks, Karen. Awesome. Thanks, Dylan. Thanks, Meredith. Sorry about the earlier interruption. We will carry on. We're going to talk very briefly about how treatment also functions as prevention. You'll see that abbreviated as TASP. And so very kind of succinctly, antiretroviral therapy treatment for HIV when taken consistently results in viral suppression. So looking at this graph, the virus is represented by this red or orange line. Someone starts on antiretroviral therapy, that comes down below detectable levels, or 200 copies per ml of blood. And as long as patient stays on that medication, their virus will stay suppressed. We call that viral suppression at less than 200. And sometimes in the medical record, you'll see not detected. That has to do with wherever the threshold of the assay is, which at this point is much lower than 200. Go ahead, Meredith. You can hit the next thing. And so as it pertains to preventing new HIV infections, you'll often hear, and I hope you have heard, undetectable equals untransmittable, or U equals U, and I'll show you some of the data for that. But bottom line is antiretroviral therapy prevents HIV transmission through sex. It also prevents morbidity and mortality as it pertains to both HIV and non-HIV related causes. Next. I will gloss over this very quickly in the interest of time, but the early kind of studies with showing that higher viral loads resulted in more transmission events. That's essentially what this forest plot shows. Go ahead, Meredith. In 2011, early results of the HPTN 052, the trial listed in the first row here, were presented at IAS, and then in 2016, the final results were published. And what this was a randomized controlled trial, randomizing serodifferent couples, so one partner has HIV, the other doesn't, to either get antiretroviral therapy right away or wait till their CD4 dropped below a certain level that was in line with country guidelines at the point, which was usually at that point in time, which was around 350 T cells, and these were done sort of across the world. What you can see in that randomized control trial is there were 78 new infections total. 46 of them were linked to the partner that that person was supposed to be with. Once they sort of looked at when that infection occurred, they either all occurred in the arm where patients were getting therapy later, or if they occurred in the arm where patients got therapy up front, the new infections occurred before the person with HIV was undetectable. And so this definitively proved you cannot transmit HIV when your virus is suppressed. This was in heterosexual couples. The rest of the slide shows observational data with literally hundreds of thousands of sex acts that didn't result in transmission. Go ahead, Meredith. This treatment as prevention as it pertains to antiretroviral therapy goes beyond sexual transmission. So we think about perinatal transmission here as well. Transmission at the time of birth is far less than 1% when the woman remains virally suppressed throughout the duration of her pregnancy. There's some numbers on this slide from the French cohort that showed where people were with their viral load when transmissions occurred, and you can see that transmissions didn't occur when the viral load was undetectable. The graph with the red lines shows the red columns shows the number of perinatal transmissions in the state of Georgia over time. And you can see that after 2016, we dropped to about an average of 1 to 2 per year, still a couple too many. Almost all the result of women coming to care late or having a really significant impediment to sustained adherence like substance use. Furthermore, women with HIV can breastfeed their children safely or chest feed their children safely. The risk of transmitting in that circumstance is also less than 1% when done carefully, sort of under monitoring with viral load monitoring and counseling on how to do that properly. Go ahead to the next piece. Injection drugs, we know that's another modality of HIV transmission, not a hugely prevalent one in our area, but it does exist. We don't have the empiric data to say that viral suppression eliminates transmission via injection drug use, but we suspect it has some impact. But because we don't have the data, we still recommend safe injection practices, even if someone is virally suppressed, in order to prevent HIV transmission. So how does treatment as prevention work at the population level? Go ahead. Meredith showed this slide earlier, this first kind of group of columns that show that 40% of 40% of new infections come from people that have not yet been diagnosed with their HIV, whereas 60%, which is these next two columns, come from those who are living with HIV, but they're not suppressed. And this last column is the folks who are living with HIV and are suppressed, who represent no new infections. Go ahead, Meredith. There's a really poignant example from British Columbia that illustrates at a population level how both sort of treatment as prevention and then PrEP as another layer really impact transmission. So if you look at this busy graphic on the left, the teal line is antiretroviral coverage. So you see that it's kind of going up in the late 90s, early 2000s with kind of overarching antiretroviral therapy, abbreviated HART. And then sort of 2010-ish, when treatment as prevention hit the fray, had increasing prescriptions. And in the red line, you can see decreasing number of new infections, which sort of plateaued with regular approaches to ARVs. And once we knew about treatment as prevention and really started to scale therapy aggressively, started to see a decline again in new infections. Go ahead to the next. This shows the R naught that was modeled for HIV infections. And you can see in the first column, pre-ARVs, the R naught was greater than 1. With each addition of an intervention, regular ARVs, treatment as prevention, and then finally treatment as prevention with PrEP, you see that R naught kind of stepwise go down all the way to 0.2. Go ahead, Meredith. And at a population level, this is just sort of a nice graphic that shows how this works and how PrEP and treatment as prevention work together. On the left-hand side, this is before PrEP. And so if you think about the red circle being those with HIV that are sort of posing risk to the greater community because they are not suppressed, you can shrink that by increasing this blue circle to make more people suppressed, but you're still going to have some folks with HIV that aren't suppressed. That's where with the green half circle, if you layer on PrEP, that the rest of the population who sort of remained at risk because there are folks living with HIV who are not virologically suppressed, they can then protect themselves with being on PrEP. Go ahead. What does this look like in Georgia and how well are we doing? We're not doing great. Viral suppression is represented with this red column. So among 62,000 people living with HIV, 63% are virally suppressed. That leaves about 30,000 people in the state of Georgia that are not suppressed. And even among those retained in care, which is in the orange column, 91% are virally, of those retained in care who are virally suppressed is great, but it's still about 10% of the population who aren't. So another 3,000 who are actually coming to their visits, but we haven't successfully gotten them suppressed. So here's our opportunity at a population level. Go ahead, Meredith. We were talking a lot about prevention of HIV transmission with antiretrovirals. There are great data too to show that it decreases morbidity and mortality, which is what these two trials show. The Insight and Temprano trials were very similar, where they randomized people again, and these are all people living with HIV, to either early antiretroviral therapy, getting therapy right at the point of diagnosis, or waiting till their CD4 count fell. And inevitably, when we waited, they had more AIDS-related and non-AIDS-related adverse events, as well as more mortality. So better to start therapy earlier for people's individual health. Go ahead. So when do we treat? The answer is now. If we say no, think stigma. Oftentimes when we're saying no, it's internalized as stigma. There's something wrong with me. I'm being told that I need these drugs to save my life and to prevent infections. Why is this doctor in front of me not giving me that drug? There was a study done at Hopkins 30 years ago that showed an adjusted odds ratio of a prescription for ARVs was 0.6 for African Americans as compared to whites when they were controlled for all other factors. The problem was the doctor. Let's not be the problem. Opt-out testing leads very naturally into treatment programs. We know that rapid treatment improves linkage, and we've been doing rapid treatment, in other words, treatment on the day of infection at Ponce for about 10 years now. Go ahead to the next, Meredith. These are things that often stop us from prescribing ARVs: houselessness, other social determinants of health, substance use, mental health disorders, our systems. I will encourage you to have you think about how to effectively get folks ARVs and what programs they need to be linked to, but it should not be a reason to not prescribe therapy. And if it's the system that's the impediment, we should push back against our systems. Go ahead to the next. There are very few circumstances where we don't prescribe antiretroviral therapy. If there are symptoms that suggest there's an underlying OI, we want to at least pause and think and investigate. So go ahead and get ID involved. There's really two main clinical opportunistic infections, cryptococcal meningitis and tuberculous meningitis, that are the absolute reasons we don't start ARVs. But otherwise, we're generally starting unless the patient tells us they're not ready, which again, it happens, but rarely. And when they say that, we say, okay, and we say, tell us about that. And we walk with them on that journey until they are ready to start. Go ahead. So now thinking about sort of the next phase, as Dylan so eloquently talked about, long-acting prevention modalities. We do have long-acting treatment modalities. And to me, this is really a new hope for treatment as prevention. It's endorsed in guidelines for people that are not suppressed, but that's still an off-label use as it pertains to the FDA. So it's a approved therapy for those who are already suppressed. It's given every 4 or 8 weeks as an injectable therapy. We have over 800 on therapy at Ponce. 91% of those have persisted on therapy. Over 99% who have initiated with viral suppression have maintained that. But again, we've been aggressive about trying to get those who are not suppressed on therapy. Thinking back to that graphic that I showed you a couple of slides ago on the right here, I'm thinking about these 30,000 people in Georgia or 3,000 that are already in our clinics that aren't suppressed. And among that group, we've achieved viral suppression in 93%. If you want to click the button one more time, Meredith, this shows the decline in the virus, kind of in individual patients. And what I don't have is a pre-therapy graphic, which if I had it, it would show preceding this that most of these patients were viremic for 2, 3, 5, 10 years before they got on this therapy and then finally suppressed. And that's thanks to a really large team at Grady and Dr. Collins and Dr. Aldridge, who really lead this program and have for years and made it what it was. But I think it's our hope of using a biomedical tool to overcome a lot of our social challenges that impede viral suppression and therefore prevention. Go ahead to the next slide. So unfortunately, all this is a moot point if we don't have funding, and that is under unprecedented threat. HIV has always been supported at a bipartisan level, always, always, always. In fact, the new HIV initiatives usually come under Republican administrations. Currently, these big buckets of funding, Ryan White, our Minority AIDS Initiative, and the CDC, both as it pertains to prevention and some global treatment programs and research programs, are under significant threat, upwards of $2 billion. Next slide. What does that look like for us in terms of new infections? A group last month published a paper that modeled what happens when our funding gets interrupted. This graphic on the top here, the horizontal line shows what we would think would happen to new infections between 2025 and 2030. Should we have sustained funding? On the graphic on the left, if all funding were eliminated, we'd have an excess of 75,000 new infections. On the right, if there was a brief interruption, we may have an excess of 30,000 new infections. When we break that out as to where that occurs in our country, on the right-hand side, you see the cities that will bear the burden of that. Atlanta is number 5, which would have 6,000 new infections. With all of those folks I showed you are out of care already in the state of Georgia, I can tell you we cannot afford this. The next animation will give you an opportunity to call your representatives and encourage them to continue to fund HIV and also get out and vote in our local elections today. Thank you guys for your time. Sorry about the interruptions, and we're happy to entertain questions.
I have a quick question for those who can stay on. Thank you all for your fantastic presentation. I'm so glad that we were able to get back up and running with a peak of 99 participants back. So I think we were able to reclaim so much of our original audience. My question actually goes back to, some of the stuff that Meredith presented at the beginning about serostatus neutral testing, because this came up in our clinic recently. And I grew up in the era where it was pre-electronic medical records. And when you wanted to test someone for HIV, you had to go get a piece of paper. You had to have them sign it. We had to have a conversation. And so now that is ingrained in my clinical practice. We no longer have them sign the paper, but I discuss it with my patients. I would like to send an HIV test on you because I have these concerns and I test them in everyone. And is that okay? And I realize that that might be like a state by state expectation. What are the requirements now for having a patient agree to opt in or out of HIV testing?
You want to take that, Meredith? Or Dylan? She's muted. Meredith, you're muted.
Okay, sorry, it was Karen had.
Sorry, I think I like imposed the mute on you. Okay,
No,
you're
no,
good.
that's fine. I appreciate that. That's a great question. So verbal consent is required in Georgia. And so in the setting of, when I think about it, I think, okay, you've got a time-based, I'm just going to test you. It's just time. It's normal. Making it a normalized part. And so that can be like, hey, I'm ordering all your tests today. That includes an HIV test. Is that okay with you? Where you do not have to justify your concerns. In fact, I would say if you're testing for a concern, that's a different type of testing and should happen more or earlier than your time-based testing, which should happen annually with people with any possible ongoing exposure and up to every 3 months for people who, like sexual minority men or people in serodiscordant relationships, etc.
You have a question, Carlos?
Yeah, muted is hard to ask a question. Yeah, no, first of all, great job. Important information. I do think that there's the big challenge here, Jonathan, is obviously where we are and where we want to be. As you and I know, opt-out testing is, I call it, opt-out testing in healthcare settings, I call it the most ignored CDC recommendation ever made. Nobody does it. And, we could have done that a long time ago and it would have been a big difference. But what I would encourage people is that HIV prevention and the diagnosing of people is everybody's job. And I don't, you could be in rheumatology clinic, you could be in primary care clinic, and order an HIV test. It's part of healthcare maintenance, and I think it's really, really important that we include it there. It's not, don't pass it to somebody else. And at least when I've done, years ago when I did have to study opt-out testing in the urgent care center, I mean, the biggest challenge, the biggest fear people have is that the test is going to be positive, because then you have to deal with it, right? It's not that the test is negative, but it's those people who the test becomes positive, and then what do? You're not prepared to deal with it. So what I think we as healthcare systems need to have is available social workers and people to take care of those that test positive and to provide the appropriate linkages. So to take that burden of responsibility away from the person who ordered the test, because, it may take another half hour to an hour of your time or more once the test comes back positive to do all the linkages and things that need to be done. So clearly, figuring out how to deal with positives, I think it's a clear opportunity to do this. But then, of course, in that serostatus neutral, what Meredith said is absolutely true. In those negative, use the opportunity to discuss PrEP. I mean, the fact that somebody came and you ordered an HIV test and you didn't discuss PrEP is a really missed opportunity. You could have prevented somebody from getting infected by not having that discussion. So sometimes you may not prescribe the PrEP, but you at least start the discussion. So, I think we need to leave here. This is why it's important that we put this in grand rounds, because this is everybody's responsibility. Thank you.
All right. Thank you, everyone for being here. Thank you to our hurdle speakers. Really appreciate your flexibility and your passion for this very important topic. And thank you everyone else for coming back and regrouping with all of us. We are very sorry about today's interruption and will reflect on our security strategy, see what we can do differently going forward. But thank you all for being here, and I hope you have a great rest of your afternoon. Bye, everyone.